not the most efficient one, but when you consider the soft tissue having uh, the ability to displace the prosthesis down, the clasp tip, the retentive element, is going to go away from the undercut. Okay, so that should be pretty clear to everyone. Now, going back to, I'm gonna go back to my blackboard. Going back to the blackboard here, and someone asked me something about anatomical. Can we discuss anatomical limitations and what you would do in different cases and why? You can all hear me, right? Make sure. Okay. So when you look at the RPA system, especially, and Dr. Ferron in the exam says, okay, by the way, there's a really deep soft tissue undercut close to the gingival margin of the tooth on the buccal. The I bar from the RPI class assembly having to come, if there's a survey line here, having to come from underneath the tooth, which we call infrabulge class, because infra means obviously underneath or beneath. If there's extensive soft tissue undercut here, we can't really have that well made, well cast. Otherwise, it's going to have all these. It's just very difficult for technicians to have this class that's going in and out of the undercut, as well as we're not going to be able to put the prosthesis in and out without really hurting the soft tissue there. So this is one good example of how we have to think a little bit differently in terms of the anatomical limitations that's given to us. Instead of having an infrabulge or I-bar class, we're going to do something that's superbulge, meaning it's going to now come from above the tooth, something like this, and engages the undercut below the survey line on the mesial buccal. So if you think about, okay, general things, anatomical limitations, I'm going to go away from infra, go to a superbulge. Now the superbulge class, there's not a single superbulge class that we've taught you or is shown you that has retention somewhere in the middle of the tooth. So you should be thinking mesial buccal retention, okay? Especially in a situation like this where I'm going to do more of a circumferential clasp on the buccal of that tooth, okay? Now, third detail, and again, you should be really paying attention to, is instead of having a circumferential clasp, we call it a cast clasp. Basically, it's a very rigid clasp because it's been cast in the whole process. We're actually going to use something like a rot wire. So if you think about the wire that you've been bending for ortho or even for our course, the RPD course, that's type of material that can give more flexibility to the arm, which also means that it's not going to put so much variable force on the tooth, okay? So you see how my mind just kind of rolls. Okay, anatomical limitations, I'm going to go away from infrabulge design, I'm going to go to superbulge. So I've kind of changed the, I guess, type of the class. Now I'm going to think about, okay, where is going to be the retentive area, not middle of the tooth anymore. And then lastly, the material, which would be, or the type of the metal, wrought wire as opposed to cast metal. So far, so good there? Great. So I could draw some. We can go over some drawings together if you want. Then, wow, it's been an hour already almost. So just shout out what you like to do. If you have questions, I can keep, we can keep discussing, keep talking, or I can draw stuff. What about buccal tilt? Okay, so buccal tilt. What about buccal tilt? how does that affect design? Is that the question, basically? Okay, it looks like there's another question. So let's talk about buckle tilt. So back to my board. So we got this chalkboard a long time ago and never use it. Now we do. Buckle, lingual. I'm going to really simplify my drawing here. So let's think about this. If the tooth is tilted buccally this way, height of contour, obviously, as you survey this, okay, it's going to be, and you can use a physical example like this if you want. So this is kind of cute. So my teapot here, buccally tilted. Okay, height of contour is going to be more or less on the occlusal aspect. As it's tilted lingually, now the height of contour is closer to the soft tissue. So in a situation like this, obviously a couple things can happen. One, you could end up having too much of an undercut below the height of contour. So what we have to do is we have to modify and get rid of this height of contour. Now, when you put a burr through, as you have done on your tripod on teeth, that actually relocates the survey line or height of contour to something a little bit lower. Okay? So now this triangle, which used to be much bigger and much greater in undercut, has become less. Okay, and it's also located away, further away from the middle of the tooth. Okay. Oh. Let's see. Wow, lots of questions here. So sorry to call you out, but Lisa, can you elaborate more on what you want to know more about buccal tilt? If you're a buccal tilt in class, the only indication. Blah, blah, blah. So, what kind of class would you do? Oh, great. Yeah. So obviously, if you pick in for a bulge, we're all going to have a stroke. You want to use something like, to me, and again, you can get different answers on this one. Once you have addressed this tilt to decent extent where, now the survey line is well below, depending on the situation, you can consider either Rottweiler or circumferential. Obviously, if this is a distal extension tooth, you want to think about Rottweiler. If it's a candidate class 3 situation that is completely a tooth-borne, you can use circumferential. Okay, which one is right? They're both right. So I often think about people being very passionate and adamant about their own design being the one over other people's designs. That's their opinion. You ask different dentists, you're going to get different designs. And I think that even this exam, Dr. Perron has made it simple enough that you don't have to think about so many different possibilities or different types of designs that you could do on a given situation. Could she test you on what else could you do? But she's only going to make you think just maybe one other alternative. That way you keep your design simple. The more you think about different ideas, the more complex it gets. And the more complex it gets, the more difficult it is to basically make the RPD successful. Is that, Liza, or Liza, is that this shown? An answer? So Rottweiler is a Super Bowl. Yeah, you're welcome. Thanks for that question. Good question. Let's go back. If you have class 2 RPD, can you use Rottweiler class anterior to the fulcrum? I saw an example where that was the case. Is this an exception to the fulcrum rule? So just like the one I drew with a distal extension and a premolar having Rottweiler class, yeah. Short answer, yes. Oh, I think, Ariana, I think what you are trying to say was, if you say fulcrum was away from the class, are you saying this example had distal rest? Yeah, sorry, I'm a little bit slow with the question. So, if there was you guys will see a lot of these drawings or any kind of designs, if you Google anything, and from above, if the clasp was on the buckle, is this what you saw? Retention is anterior to the, yeah. So fulcrum line being here, if retentive element was mesial buckle, absolutely. And again, this is class 1 lever. Yeah, you can share that example if you want, but is this pretty much what you saw, Ari? Yeah. So class 1 lever, not a great design. You could certainly consider mesial closal rest with a Rottweiler, distal guide plate, and that'll be fine. Now you have non-class 1 action going on this tube. But they said you can solve class 1 lever by, yeah, so this is where people's opinions differ. Is it true that Rottweiler is more forgiving because it's more flexible, that you can reduce some of that forking on the tooth? Yeah, I can say that could be a valid consideration, but the fact that when I think about what is more ideal, what is simpler, and if we can ideally put a mesial closal rest, and this is simpler in that we get rid of class 1 lever actions, I say why not do that? No, I need to talk to someone with this type of opinion and really get at, why would you want to do distal closal rest as opposed to mesial closal rest? If the person says, well, there's a large composite or amalgam restoration on mesial occlusal, I want to avoid that. Or maybe there's a tooth mesial to this really crowding. We can't really put a minor connector between the two teeth, and we got to go to distal occlusal rest. Fine. But at the end of our discussion, it doesn't change the fact that having a distal occlusal rest pulls down the tooth this way. Okay? And with a retentive element on the anterior to that, that's still class 1 lever. Okay? Did I beat that to death? Yes. Correct, yeah. A lot of clinical situations you'll run into in the next couple of years, you'll never see 100% ideal situation. A lot of times, there's something anatomically changing, whether it's a tooth, whether it's a soft tissue surrounding the teeth, that really kind of forces us to consider alternatives that may not be ideal. Okay, so someone asked about lingual plate, lingual bar. The simplest, the first line of thinking is, again, based on anatomical limitations. Someone already answered that, I think. Plate is when you have less than 8 millimeters of space on mandibular. Now, specifically, where in the mandibular arch? We're really talking about the sublingual area, lingual to the anterior teeth, extending to the edentulous areas, basically. So you'll see often a picture of someone putting perioprobe on that. Basically, perioprobe lingual to the anterior on the mandibular arch. and seeing if we have 8 millimeters of space. If you don't, then you need to consider lingual plate. The other situations why you might consider lingual bar, let's say we have plenty of space on the sublingual area. What would force you to choose lingual plate over lingual bar? And again, I'm talking about potential anatomic limitations. Anyone? Am I still on? I see my face. Okay, loss of potential. Okay. Tori? Awesome. Anyone want to elaborate on any of these answers? Severe lingual inclination of the anterior teeth. Yeah, that's a possibility. Not always. I look at the depth as more of a driving factor why we want to consider lingual bar. And if there's depth, even with the severely inclined teeth, I may still choose lingual bar if possible. Tori, obviously, we have to go above those, so that's why we would choose lingual plate. Lingual bar, if you do not have anterior teeth to place the lingual plate on. Yes and no. No, because if you have lingual bar, it's actually difficult to connect teeth to that. So you actually want lingual plate, because the lingual plate will allow lattice to be attached. Or some people would put extensive lattice to the lingual bar. So it kind of becomes just one piece. It's really, if you look at lingual bar, here's a picture I'm about to share with you. Share, you know it again. So if you look at this picture, obviously at the very bottom, pictures are so small. We're putting probe there, just looking at the depth of the mouth in the anterior region, and you hope to find at least 8 millimeters from the gingival margin from the depth floor of the mouth. Lingual bar, oftentimes you don't see any kind of lattice connected to it. Only thing that's connected to it are minor connectors. So again, going back to severely tilted anterior teeth, if there's sufficient depth, I'm going to do lingual bar. If there are no anterior teeth, now I'm going to have a lingual bar that has to have a lattice to it. So for that reason, I may actually choose a lingual plate in that situation. Why? Because I don't really have to have something so deep in the patient's anatomy. I can have a lingual plate that can be away from the floor of the mouth and have lattice retention to set teeth. Did I explain that well enough for you guys? Anyone? Any other questions? Anything else you want me to do? Or go over? Not anything,
Dr. Choi.
but in terms of IB.
Dr. Choi. Can you hear me?
So here's an example of lingual plate, obviously. So in reality, this is a lot of hardware, but it's a situation where we don't have that 8 millimeters of depth. And again, just going to see this one especially, you don't see much of a depth on this one. You have metal framework basically covering some portion of the teeth. I think Zach mentioned that severely tilted anterior teeth, if you want to consider lingual plate, the issue there I have is because the teeth are tilted severely, if you put any force with from the metal framework, the force is going to be labial, which is probably not the force that you want on those teeth. So again, if there's enough depth of the floor, I'll choose lingual bar, not have any contact on the lingual of the anterior teeth to put force off of it. When a lingual plate is designed, it has to exert force parallel to the long axis of the teeth if possible, which is almost impossible anyway because all the anterior teeth most of the time have some sort of tilt labially. I can't hear you. You may have to.
Can you hear me now?
I'm not sure. I'm going to stop sharing Keynote. Let's just see if I can get stuff off, but I'm not using so much bandwidth. So Fred, I can't hear you.